Good afternoon, Bahamas, and welcome to the Hit Back. I'm your host, Nahaja Black, Guardian Radio 96.9 FM. I hope that everyone is doing well, that you are taking care of yourself, that you are living your best life. All right, ladies and gentlemen, I'm really excited about today's show. You know I have been for well over a week now, really after being informed by Mr. Depute of this human being that is doing some exceptional work in another part of the world, a part of the world where most of us probably will never go, but we understand our connection to the continent as well. Finding out that there is a brother doing some amazing work there medically with regard to COVID-19, not just amazing, but really bringing some illumination, some revelation into a pandemic and a virus that has really captured us, that has held us hostage in our economy, in our medical system. We are a country that's almost at 600 deaths with only 400,000 people. What has been done seems not to be working. What hasn't been done seems to be a lot more than what has been done. And so there is a thirstiness, a desire for more information. This more information, ladies and gentlemen, when I had a chance to speak with this wonderful doctor from South Africa, it began to elucidate. It began to give me chills a bit, because then you found hope. And I think that's the thing that's been missing in this narrative is hope. What is the hope of us being back to normal, restoring our economy, not having mothers and sons being buried together, not having mass funerals, not being widowed or widower? Again, I go back to my friend who's now a widower. I go back to Dr. Susan Lockhart, who's a widow, who was on the front line losing her husband to COVID-19. There are so many of those stories. And the question is, what if those stories did not have to be? And so, ladies and gentlemen, this doctor in South Africa has been doing some amazing work that makes you pause and say, these things may not have to be. This does not have to be the Bahamian story. It doesn't have to be the world story with COVID-19. So, ladies and gentlemen, without further ado, Dr. Shankara Chetty from South Africa. Dr. Chetty, welcome to the Hit Back.
Thank you for having me, Nahaja. It's a pleasure being here.
It's a pleasure having you. Thank you so much for the time. Of course, we have this time difference by 6 hours. So our interview has to be pre-recorded, but by no means is it delayed. Is it anything else but a fresh story for us in the Bahamas? Again, thank you for the time. Dr. Chetty, I know my audience, I know my people, my country. The first question they're going to ask is, who is Dr. Shankara Chetty? When we were on the phone, when we first spoke, you dove right into we dove into the methodology, the ideas, the concept. How did you come to get to 6,500 patients, 0 deaths, 0 hospitalizations, no need for oxygen? But before we get to that, which everyone is thirsty for, can you give folks an idea of who is Dr. Shankara Chetty and how are you in this conversation with COVID-19 and alternative approaches?
I'm at the moment a general practitioner in South Africa. I run my own private practice. Nahaja, just some history behind that. I grew up on a farm in a very rural setting. My dad ran a bus business, so I grew up as a grease monkey. But as all fathers do, he wanted something better and insisted I do science and dreamt of his son becoming a doctor. I graduated with a Bachelor of Science degree in genetics and advanced biology from the University of Outpatient, and then went ahead and added microbiology and biochemistry to my degree, at which point I found jobs very difficult to come by. Strangely enough, I was looking at the Virology Institute in America at the time to find employment. A friend of mine was studying at a university in India doing medicine and bumped into my dad one day and mentioned his university. And so I applied there. I wasn't getting any joy here in South Africa because of apartheid and the quota systems at the time. So I applied to this university, JSS Medical College in India, and I was promptly accepted there. I never did see myself as a doctor. I'm not a very uptight, strict, straight kind of person, and I perceived doctors to be such. But my dad always encouraged me to be the kind of doctor I wished to be. But I was always an inquisitive individual. And so I got back to South Africa in 2000 and did my internship in community service. And unfortunately, being out of the box kind of thinker, there was always polarization wherever I worked. And by default, I landed in this picturesque town called Port Edward. Without a job, I was looking to buy a practice in the rural Eastern Cape, which fell apart, and I had moved my family here in anticipation of that. So I found myself in this town without a job. The few people that knew me insisted I open a private practice, at least to serve the community. I thought, well, I like the place and I should try. It's been 20 years that I've been here. And I think in a quiet little quaint village that I live in, I've been allowed the latitude to practice my brand of medicine without the prying eyes of the so-called experts that we see today can be pretty flawed. And yeah, with the pandemic, I got thrown in the deep end. I had to call on all my education, and I guess the rest is history.
It's history. If you're just tuning in, Dr. Shankara Chetty from South Africa, Port Edward, South Africa, chatting with us today. You know, your story of getting into medicine, I think it's always a great story of how we end up where we are and how we end up in a space where we were probably destined to be to answer some of life's great challenges, right? Some of life's great questions. Well, Dr. Chetty, one of the great dilemmas of the world today is COVID-19. COVID-19 is the great dilemma of the world today. And I want to ask you, from Port Edward, and to give folks an understanding, Port Edward is what do they call it? I would call it like just like a boutique sort of town, right? Travelers, visitors, leisure travel, by the beach, by the ocean. It's that sort of boutique type of community. But is my assessment right? Give folks an idea of the type of the demographics of Port Edward.
Port Edward, yes, it's a town with a lot of history during apartheid. It was a whites-only community prior to '94, a very beautiful holiday destination, the playground of a lot of retired folk. So it was a journey coming and setting up a practice here. But it's surrounded by very large rural settlements. So I have a very wide demographic of patients, young and old, but in all different race groups, all different socioeconomic groups, the most diverse, all different ailments, comorbidities, the whole toot. It helped me well in all these years to try and forcibly integrate my community, and I've taken pride in doing that. I've been very active in the anti-apartheid movement in the 80s. And so Port Edward's been a place I think I was meant to be. I was one of the first, if not the first, non-whites to move into this town. So I faced a lot of ostracism and racism and the rest.
Oh, wow.
But that's changed over time. I've brought people together. I've made sure that they start to recognize and realize each other's worth. And so it's been a journey. But from a patient perspective, I'm blessed with the broadest diversity of clientele from all fields of life, from all socioeconomic groups, from all races. And I think that's allowed me latitude to see everyone the same. I think there's God in each one of us, and sometimes we tend not to recognize that.
Yeah, and I wanted to. It was intentional for me to ask about this demographics because that is similar to the Bahamas, where we have affluent to extremely impoverished, right? So that, and we are, of course, we're an island nation. And so we understand this coast. We are a holiday destination, folks, a place of leisure. So you can see the wealth around you, but yet we have crumbling health infrastructure where we don't have sufficient. We haven't had sufficient health facilities, even when it was outside of COVID, to deal with the pandemic as we are now. All of that matters when we have this discussion. And what you have been doing. Let's start at the beginning of this pandemic, Dr. Chetty. When did you take notice of COVID-19? When did you take notice? And what were some of the things that came to mind as we started to look at COVID-19?
I think with my background in the sciences, the natural sciences, when COVID started in Wuhan, and of course, it was noted that there's the possibility of a pandemic, that's when my interest was sparked. I wanted to understand what we're going to deal with, what's new about this virus. So every nuance of what was going to transpire interested me, from the science of the virus itself to the medicine and how it would impact clinically on patients, how it would cause the mortality and morbidity, how it would spread. My diversity in my science background covers all these fields. And so I was interested in almost everything about it. But information was lacking, and so I had to pick at the little that we had available to us and try to figure out a picture of what to expect. If this was going to turn into a pandemic and reach the shores of my country, then best I be prepared. And of course, I wanted to be at the front to try and understand this. And so I watched the knowledge that was being shared around the world, and I drew up a perspective of what to expect. And I think that held me in good stead once COVID got here. So I looked at this in all directions, from the way it spreads, the epidemiology, the kind of population it would affect, the whole truth, the clinical presentations, what we were seeing from that perspective, the comorbidities, how it was influenced, the COVID in its entirety. So from very early on, I had a view of what I'm going to be dealing with.
And when you look at it and you say you had a view of what you were going to do, now you're watching it. We're watching this virus lockdown Wuhan, China. We're seeing the anxiety that is building up now in the United States. We're seeing Italy now beginning to take a brunt of it. The world is now getting some instruction, right? The world's instruction started to become lockdown, don't see your patients. If you're a physician, do these things virtually. Everyone isolate. When you heard all of this and you're listening to it as a physician, you're getting certain levels of instruction yourself. What are your thoughts when you hear as a physician, hey, okay, listen, you're not able to see your patients, everyone isolate from each other, we don't understand this virus. What kicked in for you at that point?
I'm not the kind of person to follow the rules very easily. I think my science and my understanding of the world around me is what I fall back on always. So illogic and nonsense don't sit very easily with me. When I looked at the response, it just made no sense. No sense at all. Just to put some perspective to that, the initial response of the globe was to lock down and isolate. Fair enough, we're dealing with a new pathogen. We didn't understand how this would impact on us and how it would spread. But of course, there are certain things that are reasonably written in stone. Nature has a way of doing things, and I don't think I needed to throw out that rule book and start to listen to some illogic, or as I saw, illogic around me. So in all of history, we have never been able to successfully isolate a respiratory virus through isolation measures, or prevent its spread through isolation. This is an airborne virus and we can't see it. So isolation was always targeted at sick people to prevent the spread of the infection. We never, ever in history attempted to isolate asymptomatic people, let alone entire societies, to prevent its spread. And of course, if you want to find the virus and understand it, then isolation of your community would not be the ideal measure. You'd not understand how it was spreading because everyone was isolated at home. Respiratory viruses also spread in close confines. So I couldn't understand why you would want to confine people, where one person could pick it up and spread it to the rest of the family. Secondly, respiratory viruses tend to, the most common thing used to curtail the spread of respiratory viruses is sunlight and ventilation. Social distancing, yes, but keep apart from each other. But sunlight and ventilation are the most important things. And I couldn't see how that was suddenly abandoned. Yes, there is the sanitary measures that go with it, so the hand sanitizing and the rest is important. Uh, but respiratory viruses generally do not spread very easily through fomites or contact. So even the preoccupation with sanitation or hand sanitizers I found illogical. People were going crazy, sanitizing all their supermarket wares, constantly sanitizing their hands. I just couldn't understand that. So I decided that I'm going to fall back on my knowledge and place my faith in God and the nature that He's shown around me and take the risk and start to see patients and try and understand this illness. So from the start, I've been pretty wary of what I've been told because it hasn't made any scientific sense to me.
That's that's so interesting because of course we're always told follow the science, right? Follow the science, right, Dr. Chetty? That's the thing. We are to trust science. And we're gonna go to that line as well, but I want to hit on some other things before I get to that because I think there's a reason why there's a lot of challenges with the science, right? Challenges with telling the story or getting people to buy in or to join on to the narrative is because some things just don't add up. But let's go into your work now. Let's go into what you started to discover. You decided to see patients, and this is when did COVID-19 for you for South Africa land at the doorstep? When did COVID-19 enter South Africa?
That was in March 2000 that we had the first reported cases of COVID in South Africa.
March 2020, yeah.
Yeah, that was the first. At that point, there was a lot of information globally about the presentations in hospital, about the nature of the illness in hospital, and of course the deaths. But there was also a controversy that COVID was actually a flu-like illness because a lot of people were reporting that it was just a flu. And so it sparked this debate about this being a hoax and, it wasn't as serious as people thought it was. But it was clearly a very dangerous illness. We were seeing people getting very breathless and getting onto ventilators. People were dying. So I knew for sure that there's definitely an illness out there, and I needed to have an open mind and look at this very pragmatically. So the work that I wished to start at that point was to try and understand the illness from its initial symptom to the point where a patient might require hospitalization. I felt that there was a lack of information in that early part of the illness. Yes, we knew that people were getting into hospital critically ill, very breathless, but we did not understand how they got to that point. So our interventions were a little late. And so it was my aim to examine every patient from the day they fell ill and to understand the progression of the illness and how it evolved over time before patients got to hospital in the first place. Of course, there was this panic and fear around the world, and I think that was causing a lot of problems. Very early on, my patients came to me and said, look, there's this word out that we must isolate and not seek medical attention. Doctors were encouraged not to see patients and do telephone consults rather in an attempt to curb the spread of this infection. I didn't think that was very sensible if we hoped to quickly understand it so that we could control it. So I gave them the reassurance that I would make myself available to each and every one of them and keep my practice open. And so I had to find ways and means of ensuring the safety of all around me, whether infected or not, and to keep medical service to my area constant. I'm situated very far away from any secondary or tertiary services. The closest hospital to where I live is 35 kilometers away. So I've become accustomed to doing a lot myself.
Oh, wow.
So I do in my practice provide a diversity of service to my community. And so I'd hoped that I'd use that diversity to understand this illness a little bit better.
Mm-hmm. We're going to take a quick break. We've got Dr. Shankara Chetty. And now, Dr. Chetty, when we come back from the break, what I want to find out more is now that you're now seeing patients, what did you start to discover? What did you start to learn about this virus? We're going to take a quick break. When we come back, more with Dr. Shankara Chetty. You're listening to the Hit Back with Nahaja Black Guardian Radio, 96.9 FM. And we're back. You're listening to the Hit Back with Nahaja Black. Dr. Shankara Chetty joining us on the show today, all the way from South Africa, giving us just great insight on the work that he's been doing that has really taken the world by storm. Before we went to break, Dr. Chetty, you're now saying, okay, listen, you have decided at this point, and it's very interesting, both yourself, South Africa, and ourselves. March 2020 was our first case, and we locked it down. That everyone remembers March 16th, one case, and the world shut down for the Bahamas. And it has been different ever since. But you decided that, hey, this is counterintuitive to the training that physicians have been trained under for decades, for centuries. You see patients, and so your curiosity took over, Dr. Chetty. And what did you start to notice with seeing patients? And also, I give folks because there's so many questions I have on that. But let's start with, what did you start to see? Because I have questions on how did you stay safe? Did you ever get COVID? This was dangerous times. And maybe I should go there first. How did you make that decision? What did you do to allow you to make that decision of seeing patients effectively, not causing spread, not affecting your staff, etc.? What did you do?
I have a pretty committed set of staff. It's my two nurses that have joined me through this journey for the past 20 odd years. Mm-hmm. So we spoke. I explained to them that I think this is a calling. We need to stand up and be counted and take care of our community. It's God's work that we do. Mm-hmm. And so I relied on sunlight and ventilation, like I've said. So I pitched a tent in my parking lot, a proper little clinic where I knew I would get sufficient sunlight and ventilation. I set up some triage measures, some screening measures, so that I can keep apart COVID positive patients from COVID suspects, and allow the interior of my practice to be used by my regular patients that were non-COVID or non-suspects. And so I set that up. I set down some protocols. I started to educate my community even before COVID arrived about the sanitizing, the social distancing, the mask wearing when in public, those kind of things. When we had the first case in South Africa, the first reported case, I moved out of my home. My home and my practice are on the same premises. So to protect my family, I found a little flat and moved out. I knew I was going to spend months isolated from community, but I was willing to dedicate my time to understanding COVID. And so it was to my flat and back every day, and my day was spent examining patients and attempting to understand exactly what was going on through the evolution of this illness. And that's how this got started.
So now we are in a space where we are safely doing it. And did you don all of the PPEs? I was always curious. Did you have all of the PPEs, the full regalia? Were you donning all of that?
No, I've never done that. I've worn a double mask and a visor, and that was that. When I went into my tent, I was cautious about spread through contact, so I put on a white lab coat. I was very conscious of what touched me. When I came out of that tent and needed to see patients that were not COVID related, I removed that lab coat and sanitized my hands. I was very aware of keeping my hands away from my face, and I taught my staff that. But full PPE, never. I'm not even a doctor with a desk in my office. I think I try to make patients feel as comfortable as possible so they can tell me their deepest, darkest secrets for me to help them. And so I don't see the need to keep a distance between me and my clientele. I was taking a risk anyway. And if I was going to take that risk and make it bear fruit, then I needed to be attached to the people that were ill and not form a barrier between me and them. I couldn't see the purpose of full PPE. I'd probably get tangled in it, putting it on and taking it off, and stand more risk of picking up COVID. I'd rather be aware of my surroundings, and that would hold me safe. In my practice itself, I put red striping on the floor so that people could keep between those stripes. People tend not to know what they're touching as they walk around, but just to draw their consciousness to keeping their hands to themselves, I marked a path on the floor so that they could keep between the red lines, and everyone walked between those red lines and not touched anything around them. So I think it's about being conscious of what we're dealing with, constantly conscious. And that's kept us all safe. I've never seen the need for full PPE. Yes, we are getting these images from around the world of people sanitizing things all dressed in PPE, train stations and bus stations and the rest. But we're chasing a respiratory virus that we cannot see. I found it absolutely nonsensical.
Yeah, and one of the things is when does it stop, right? When does it stop? So let's get to that. Now you're seeing patients, Dr. Chetty, and if you're just tuning in, Dr. Shankara Chetty from South Africa, doing amazing work with outpatient care, has had zero deaths, zero hospitalizations, and does not use oxygen in his practice. He is in a small, what they call it, holiday town, holiday city in South Africa, Port Edward, and he's joining us to tell us about his successes. Now you're seeing patients, Dr. Chetty, and what do you start to notice? What starts to happen in your observations at the beginning of this pandemic?
Before the pandemic got here, I was concerned about the diversity of severity of symptoms that I was seeing. We knew that patients were getting breathless, dyspnea. We knew that oxygen saturations were decreasing with these patients and steering them towards possible ventilation. But the one thing that stood out was the speed of this illness. There were those patients that progressed very rapidly from the onset of breathlessness to ventilation. There were those patients that got breathless but remained breathless for months, but never really got critically ill to the point of requiring that ventilation. There were other patients that started to get breathless, but spontaneously after a few days seemed to recover. And of course, there were those that had a flu-like illness with no breathlessness at all. And this was what was being reported from Italy. And so I looked at that and I thought, it's very strange for a virus to act in that way. They tend to be pretty uniform in the way they infect people. There's very little evidence of any respiratory virus causing a sudden, severe pneumonia within a day. Yet we were seeing patients going into this respiratory distress within a day. So that was the focus of my attention. I wanted to understand how people that got breathless presented. The signs, the symptoms, what did they look like, what did they sound like, and how quickly did this progress? I had an inclination from the start that it wasn't the virus itself causing the problem. It was more the host reaction to the virus that was causing this diversity in severity. A virus tends to infect your throat. It will spread into your bronchus and then progress into your lungs. And then you become breathless. And that would be the emergency to get you to hospital. So I wanted to understand this disconnect, this unusual progression I was seeing. So the focus of my work was to understand this vital onset of breathlessness and its progression. And within the first few patients that I saw, it started to shine light on what I had suspected.
And when you say what you had suspected, Dr. Shankara, what did you suspect?
I suspected to find a host response causing the mortality and morbidity rather than a virus causing the mortality and morbidity. Viruses, we're talking about a coronavirus. Now, that's a simple organism, or let's call it an infectious agent. It is constant, but we are seeing inconsistencies in the speed of presentation. So a constant cannot result in such inconsistency. So the inconsistency would come from the inconsistency of human beings. We all are different, and we would respond to something differently. So I looked at it as a host response rather than a viral infection causing these inconsistencies. And I needed to clarify that. So from the start, I somehow had a view of where to look. And very early on, I realized that it's absolutely correct. This is a host response rather than a viral infection leading to mortality and morbidity. Just to give some understanding as to how that came about, I advised every patient that I saw that they must present back as soon as they noticed that they're getting breathless. That was my focus. All patients with COVID presented with flu-like illness, body aches and pains, a sore throat, the loss of smell and taste, which was very unique to COVID illness. But more than that, a typical flu-like illness. Patients were asked to present back when they developed breathlessness. There was only a proportion of patients who presented back with this breathlessness. And of course, the breathlessness that they presented back was either mild, moderate, or severe. But very early on, I realized that this breathlessness always started exactly 1 week after the onset of their initial symptoms. So every patient that came in breathless developed that breathlessness on the 8th day, exactly a week after the onset of their illness. So I started interrogating that fact. Every patient that came in was interrogated about the onset of their illness. The first day would help me to predict the 8th day and understand whether there was a trend here. Now, we all get colds and flus, and of course, we know that day when we're coming down with something. Yes, we got our usual sinusitis and hay fever and the rest, and we know how that feels. But there's always that fateful day where you recognize that I'm coming down with something. And I made it a point to document that day for every single patient that I saw. And it was clearly obvious that patients that worsened always started that worsening on the 8th day, exactly a week later. Now, that drew my attention to this being a biphasic illness. There were certain things that just didn't make sense. I've had patients who would develop a sore throat, like with any respiratory virus. That sore throat would progress. They would get a bronchitis, would require an antibiotic, like I'm used to treating patients with viral infections that are complicated by bacterial infections. I would put them on the antibiotic and the rest, and they would recover. And over a period of 7, 10 days, recover completely with absolutely no sequelae. Then I would have patients on the other side of the spectrum who would come to me on the first day with a sore throat. I would start them on simple treatment, symptomatically, and they would recover by the very next day, feeling absolutely fine. They would continue the rest of that week engaging in sport, fully recovered, with the assumption that they're over the illness. But exactly 8 days, a week to the day, would suddenly get up feeling unwell, and that feeling of discomfort could be mild, moderate, or severe. I've had patients get up feeling just fatigued on that 8th day, and it would stay that way for 2 or 3 days and develop breathlessness. I've had other patients who'd get up that morning after being perfectly fine the day before, feeling tired, start to develop breathlessness by midday, and by evening would be ready for hospitalization and require oxygen. So it's this speed of change that fascinated me on the 8th day. And of course, looking at that kind of progression on the 8th day, I realized that I'm dealing with two separate illnesses. Some people never had that reaction. And so I started to understand that we're dealing with a dual pathology here. And I needed to figure out what the pathology of the second part, post 8th day, was all about, because that's where all the mortality and morbidity resided. No one's ever ended up in hospital in the first 7 days. And if I could figure out what was happening post day 8th, it would give me an understanding of how to treat that. So I started looking at all the pathology I've been taught over the years, and the only thing that made sense or fitted this kind of pattern was the allergic reaction we would have to an allergen. Now, we've all had allergic reactions to this or that, and we know that if we take a particular allergen, be it a bee sting or be it penicillin, there's a proportion of the society that's allergic to such. There are some that aren't and would not have a reaction to it when exposed to it. And those that are allergic to it would have varying degrees of allergy. Some would have very mild transient allergic reactions. Some would have moderate reactions, but if not treated, would persist for a long period of time. And of course, there are those that are severely allergic and would progress very rapidly into anaphylaxis and require emergency intervention immediately. And this fitted the picture that I was seeing. So I knew from the start, I think after about the first 5 patients that went into the second phase, that I'm dealing with an allergic process here that is
Let me,
triggered on
can
the
I,
8th day. Yes.
let me just, I wanted to add something just on that alone, right? So you're seeing this, if you're just tuning in, Dr. Shankara Chetty just giving us some very interesting analysis so far of what he's seeing at the beginning of this virus and on this 8th day process. You said, you noticed that on the 8th day, those who would turn would turn. So you're treating the first 7 days, this respiratory side of it, COVID-19. You're treating COVID SARS too, or COVID, however, the SARS virus that we've grown to know. But the 19, I think the part that switches is the second part, the second where it's become its own signature of this COVID strain is when we see this, what you call this duality, this other trend. When
Yes.
you looked at your first 5 patients, though, and you're noticing after the 8th day this reaction, none of those 5 felt critically ill before you figured it out. Like, how did you know what to do, even with the first 5, as they began to turn?
Look, when COVID got here, there were treatment options that were available. There was a lot of controversy about hydroxychloroquine or plasmaquine, but I'm not one to be easily swayed. Hydroxychloroquine or plasmaquine is something I've used in my practice extensively for the treatment of rheumatoid arthritis and the rest. So I was well aware of its safety profile, and I had no qualms about using it. So I developed a little toolbox of meds that I had possibilities in this pandemic. And so I was ready to use that. I actually bought up a lot of the plasmaquine in my country before COVID even came, because I knew it was going to get banned and taken off the shelves, and I could see the controversies around the world already. So I made plans. I made sure I was stocked with the right medication. I made sure that I could provide that kind of intervention for my patients. But respiratory viruses tend to be relatively self-limiting. And so symptomatic treatment is usually all that's required. So that's what I expected. I had no reason to believe otherwise. So all those 5 patients that came in initially with respiratory symptoms were put onto plasmaquine out of fear rather than any real intervention or scientific intervention. But I quickly noticed that every patient that came in, even those that didn't progress past the 8th day, noted benefit or noted recovery by the 5th or 6th day of symptoms. They got their appetite back. They felt like they're getting better. We all know when we're feeling a little better and feel like eating again. And so I noted that with every patient. But there was that small percentage who had a sudden worsening on the 8th day. So the early viral phase of the illness was absolutely nothing new to me. It was simple to treat. I didn't understand the controversies that were there. I didn't see the need for antivirals. I realized very early on that we're dealing with a self-limiting viral illness. Patients would recover by the 5th or 6th day. It was only those that got more severely ill that might require certain further intervention. Those that developed bacterial infections would require antibiotics. I limited the use of plasmaquine to those that had severe viral symptoms, severe body aches and pains, severe spikes in temperature. And so I would give them a course of plasmaquine. And it worked well. It curtailed the symptoms, if not the virus. And a majority of my patients by the 5th or 6th day showed clear signs of recovery. Quite a few of them recovered within a day or two. But that did not negate what would transpire on the 8th day. There was a complete disjoint that I had noticed. And so I had to educate patients about the gravity of having new symptoms appear on that 8th day and present timeously for a second line of treatment.
We're going to take a quick break on that, Dr. Chetty, because now, and we have to, for all of the bills we have to pay, but we'll take a quick break because when we come back, I want to ask you, how many patients at this point have you seen? Because you said that by the first 5, you noticed that you're seeing a trend, right? You're seeing this trend, and because you're already approaching it, that it's biphasic. You're already seeing and having this idea that this is already at this point where there's, this duality of this virus. What happened at this point? Now you're saying, hey, listen, we're going to check me out in 8 days. How many patients did you start to see this real trend where you're like, aha, this is legitimately something here? And we want to talk about that. We'll take a quick break. You're listening to the Hit Back with Nahaja Black, Guardian Radio, 96.9 FM. And we're back. You're listening to the Hit Back with Nahaja Black, Guardian Radio, 96.9 FM. Really excited to have all the way from South Africa with us, Dr. Shankara Chetty. Dr. Chetty, again, thank you so much for the time. Appreciate you and the work that you're doing. I'll tell you right now, we are very happy. I'm a happy host, and my listeners are very happy to hear this sort of conversation on the pathogenesis of COVID-19, what it is, what you've seen, and how you've been so successful. So let's continue on from where we left off. You're saying at this point, listen, you've seen it, you're already starting to see some trends from deciding, I am going to take a look at my patients, I'm going to be here on the ground, take the necessary precautions, but we are going to serve our community. Now you're seeing this shift on the 8th day. You're seeing these turns where some, and I want to ask the question, what percentage were you seeing? If you had 10 patients who came in, and are you, by the way, are you testing every patient that comes in at this point? Are you testing every patient?
Look, initially, it was a government protocol to have every patient tested. And government had set up sites to test these patients. So we knew all the positives around us. That's changed. I realized the inadequacies of the PCR test, and I've stopped doing that a long time now. Mm-hmm. But I would say about 30% of my patients turned on the 8th day. To understand how I started to treat this, Nahaja, steroids were being used around the world, and we knew that this is a steroid-responsive illness. But of course, as a clinician, I'm well aware of the detriment of using steroids in an infection. You could suppress your immunity and would cause the infection to run rampant. So in infection, steroids are limited to life-saving situations where your immunity needs to be suppressed to buy some time for other medications to work. on their own, they're really not that effective in infections. So the timing of the steroid became vitally important. It was part of my arsenal, but the timing was vital. And of course, seeing these changes on the 8th day made it very simple for me to understand where a steroid might start to show benefit. So initially, with the first 5 patients that came in that experienced this turn on the 8th day, I started them on steroids. Now, with any medication, the speed to recovery is vitally important. And the speed to recovery is what will dictate or enlighten on mechanism. And so speed to recovery is always important to monitor. So the first few patients that came in were given a dose of steroids and were phoned regularly every day to find out how they're feeling, and were called back timeously to have their oxygen levels checked. And I noticed initially with the first few patients that it took 3 to 4 days for them to show some recovery, and they slowly improved. I, luckily enough, in those first 5 patients, not had anyone become critically ill. There were some where I needed to increase the dose of steroids just to get a handle on things. If I didn't see recovery the next day, the steroid would be increased until I saw some recovery. And that drew my attention to doing a little more, that I needed to test this hypothesis that I had, that this was an allergy. And so I had a patient come in, I think it was the 4th or 5th patient that came in, with saturation of 80% on the 8th day. She had started feeling breathless just that morning. And by the time she got to me, her saturations were 80%. She's a young patient, relatively young, 45 odd, diabetic and hypertensive and obese. And I looked at her, I initiated the steroid. But if you are treating hypersensitivity, an allergic trigger, then the science dictates that you will have a sudden release of chemical mediators. Now, we've all, as physicians, treated patients with bee stings, and we understand the gravity of early, timeous, aggressive intervention to turn around a storm that might occur. And so I gave her a kidney's dose of antihistamine. Now, the antihistamine is vitally important. The choice of antihistamine is vitally important. And I've treated this kind of condition before, allergic conditions. And so I gave her a kidney's dose of promethazine to see whether that would enhance the speed to recovery. Now, I knew I was dealing with at least 3 days before a patient showed good recovery. And here I had a critically ill patient and I needed to do more. She was the first one that had such low saturations on presentation. And so I gave her a kidney's dose of promethazine, just a tablet 3 times a day for that particular day. And I told my staff to please give her a call in the morning and follow up and see how she's doing. I didn't see the need to hospitalize her. And when we got in touch with her the next day, she was perfectly fine. The breathlessness had disappeared. She was absolutely fine. Her oxygen saturations were back to 98%.
Wow.
So I realized that the antihistamine was enhancing the speed to recovery, and it was lending to my hypothesis that I'm dealing with an allergic process that's triggered on that 8th day.
The next day, she was fine. The next day.
The very next day. So I knew that the 1 day of antihistamine, if I was treating an allergic reaction, was not sufficient. If you withdraw antihistamines too early, you'll get a rebound in symptoms. So you've got to continue them for a little while. So I advised that she must please be cautious about a rebound in that breathlessness and report immediately. And a day later, the breathlessness resurfaced. She presented back to my practice. I started her on a full course of antihistamine. She promptly, again, showed quick signs to recovery and no sequelae. She recovered completely. So immediately that validated my theory. And so I thought, well, if that be the case, then it explains everything that I've seen. So immediately I knew that I was getting something on the 8th day that was triggering an allergic response in patients. Some sort of allergen that was exposing itself to people on the 8th day. And those that were allergic were developing this allergic reaction, mildly, moderately, or severely. And when that happens, you will have a release of histamine, but also platelet activating factor, which would bring understanding to the clotting issues we were having, prostaglandins, and leukotrienes. Now, these 4 mediators are central to any allergic reaction. And so I decided that I would treat it like an allergic reaction. So I immediately changed the way I treat the 8th day. It included an antihistamine. The early antihistamines are the ones that show the best benefit. Promethazine, hydroxyzine, cyproheptadine. The choice of medication isn't really important. The understanding of the perspective is important. And so promethazine being the most readily available here in South Africa and the cheapest of the lot was my choice. As far as leukotrienes go, montelukast is well known as a leukotriene inhibitor, and I've used it extensively in the treatment of allergies and such, seasonal rhinitis, and preventing people having allergic conditions. And so I added that to my protocol. I also added aspirin because I knew I'm getting the release of platelet activating factor, which down the road has been shown to cause clots. And we're well aware that people had a lot of clotting issues and things. So that became my protocol on the 8th day. So basically what was happening is that we're having an allergen triggering the opening of a tap in your body if you're allergic, spilling a whole lot of chemical mediators. And my aim was to quickly mop up those mediators and turn off the tap. The turning off of that tap would be steroids that would accomplish that purpose. So all patients that came in on the 8th day that showed signs of worsening were put onto those 4 medications: a steroid to turn off the tap, an antihistamine, montelukast, and of course the aspirin. And in all those patients, I saw immediate recoveries, even those that were the most critically ill. The dose of steroid needed to be tailored to the severity of the reaction. And so the one thing I had to educate patients about was recovery. Every patient was educated that they needed to show signs of recovery by the very next day. And if that didn't occur, the dose of steroid was increased. Now, the dosage of steroid around the world was always a very controversial topic. The dose of steroid is dictated by the severity of the reaction. And sometimes very high doses are required to actually turn off this tap. So it became controversial that I, in some patients, required to use such high dose of steroid. But it's necessary. The pathology will dictate the intervention, not any protocol. And so too the patient will dictate the intervention and their recovery. Now, to put things into perspective, World Health Organization put out protocols for treatment. And those protocols were being used by a wide diversity of doctors from outpatients to hospital settings, remdesivir and the whole toot.
Yes, we use remdesivir here.
Yeah, I think the speed to recovery is vitally important. I could never see the benefit of antivirals because I knew it wasn't the virus causing the problem from the start. It's the allergic reaction that's triggering the process. And if that's not curtailed immediately, you are going to have a patient that's got problems. Now, if you have a severe allergic reaction that's not treated appropriately and left to persist, that allergic reaction will slowly start to become inflammation. That inflammation, if left unchecked, will start to cause coagulation. And so the progression of this illness from the trigger of hypersensitivity on the 8th day was easily understood.
Hold on, Dr. Chetty, hold on. You just said something that kind of blew me, right? You said that an allergic reaction, if left untreated, will begin to cause, and you said you used the word slowly.
In some figure.
Yeah.
Depending on the speed.
Yeah. So inflammation. So we've heard that this is an inflammatory, that COVID-19 causes these levels of inflammation. And then you said it also would then cause coagulation, right? Which would be the thickening of the clotting of the blood. Am I correct on that?
Yes, correct.
One of the things that was been said, some people have the stories of that they would get so sick they would start coughing blood, right? One of someone that I know, one of her, before she died, was the bleeding coming out of her ears and her nose. Is very traumatic for her spouse. And you're saying that, Dr. Chetty, that this is because we did not treat the allergic reaction of COVID-19. That these are all symptoms or displays of an untreated reaction. that could be resolved. I'm sitting here stunned because I've spoken to physicians here and they're saying we don't know what's going on. We're seeing hemorrhaging, cerebral hemorrhaging. We're seeing this. Uh, Explain, how is it so simple but yet so difficult?
I
I'm
think
stunned by this.
the hemorrhages that we see, the severe inflammation or cytokine storm, is actually too far away from the scene of the crime
Mm,
for us to understand clearly. This is a simple hypersensitivity trigger that occurs on the eighth day, and if it's not treated as such, will cascade into a myriad of symptoms that will be very difficult to understand or explain or curtail or treat. So I think speed and the aggression with which you do this is vitally important. Just to put some context to that, Nahaja, if someone came to me with a bee sting and they were allergic to it, so we're talking post eighth day right now,
mhm,
some people will be mildly allergic to that bee sting and they would develop a localized reaction with a rash, uh, localized rash. And if untreated, that would usually resolve itself within a few days. Now, those are the patients that would get breathless on the eighth day, not severely so, but after a few days, with supplementary oxygen if required, and symptomatic treatment, would resolve spontaneously on their own. There are other patients who are moderately allergic to this bee sting and would probably develop a rash over their entire body. And if I did not treat them and left their bodies to deal with that, excuse me, it would take a very long time for them to recover, maybe months.
mhm.
It's a severe, it's a global response that they're having, and we are not assisting them reverse the process. And so it would take months for them to get over this moderate reaction, even though it's not life-threatening. And that is long COVID. Patients have moderate reactions, left untreated, takes forever for their bodies to fight it. And then, of course, you'd have that patient who would come in with the bee sting and would have an anaphylactic kind of reaction, would deteriorate very quickly. And if I'm not quick to respond to that, they would deteriorate very quickly. And those are the patients that have severe reactions and end up on the ventilator very quickly. So it's understandable the picture we see after the eighth day. We're seeing the transient breathlessness where patients recovered from that. We're seeing the long COVID, which is moderate allergic reactions left untreated. And we're seeing these severe reactions where patients would end up on a ventilator. Now, just to put some understanding into this, I've treated every patient in this way. The prediction of the day the bee will sting you is vitally important. Now, if you had a bee sting and you're severely allergic to this, and I did not treat you, and I said, look, isolate at home, it should get better. If you feel you're going to die, then get yourself to hospital, someone will take care of you. Then 3 or 4 days later, you would definitely realize that you ain't going to make this on your own. And by the time you get to hospital, you have already endured multi-system damage. You've allowed this to damage your heart, damage your kidneys. You've put your life at risk. The problem is when you get into hospital with all this multi-system injury, the doctor there has no clue that you were stung with the bee. And so he has no clue where to start to treat this. So that's where the problem lies. We are now trying to treat symptoms and reverse symptoms without understanding the cause, the
Mhm.
initial triggering event that got you to that point. So it became vital for me to predict the eighth day for every single one of my patients and enlighten them on such, so that they would know the particular day when this illness will turn and to report timeously for treatment, intervention. It's a silent bee sting. We don't see the bee. We need to recognize we've been stung. And so, drawing your attention to that vital day in your evolution of the illness, that education, has been vitally important in me saving patients' lives. They got to know when to come back and when the second part of this starts. After all, it's that part that causes all the mortality and morbidity. I'm sure for your listeners, if they've had friends and family that have passed away with COVID,
Mhm.
when they ask about those friends or family that have died, there is always this narration from family members that they thought that the victim was getting better. He seemed like he was getting better. and suddenly he took a turn for the worse and ended up in ICU. That turn for the worse occurs on the 8th day, and the prediction of that day and the early aggressive treatment on that day subverts everything that might transpire afterwards.
This is powerful. Dr. Shankara Chetty, the power of the 8th day. Okay, let me ask you this. You know, the symptoms of it, when we, for my listeners, for my audience, and I know we have physicians all across the Commonwealth who are listening, nurses who are listening, folks across the world who are tuning into the show. How do you help your patients determine that first day? Because for many of us, I had COVID. I can't tell you the first day. I can't remember. But maybe then, if it had turned, I probably would have. If I needed intervention, if I needed to see a doctor, then perhaps I would have, right? But how do you help a patient determine that they've been stung, or that, to figure out this 8th day process?
I think I can't call it fortunate, but the symptoms led me to the understanding. The prediction of the first day, or clarification of the first day, is vitally important in the prediction of the 8th. So early on, I did explain to my patients that I will be available to them, and I'd like them to present timeously when they got ill. And it looks like a flu-like illness, so don't discount any flu-like symptoms. Now, when patients come in on that early phase, I have to interrogate them. When you ask patients, when's the first day you felt unwell? I started a fever on a certain day. I started to cough on a certain day. That's not my question. The most important is the day you noticed you started to come down with something. Mm-hmm. We all have our usual. That is not my interest. My interest is that day you felt you coming down with something. And everyone knows that day.
Yeah.
And that would be written in their card as day 1. I would treat them symptomatically, but using that day exactly a week later. So if you came in on a Monday, and Monday was your day you started to feel unwell, then I would treat you, but educate you about what's going to transpire possibly the following Monday. And to be aware of any new symptoms on that day. Now, in the first wave, the breathlessness developed pretty rapidly. And so people became breathless on that 8th day. And so it made it relatively simple for me to catch them and to see the trend. Breathlessness is a symptom that's easily noticeable and would bring you to the doctor relatively quickly. But in the second wave, that changed. In the second wave, we noticed that patients were taking a little while longer to get breathless, but the 8 days still remained true. We were now dealing with a different variant. And the variant in South Africa presented on the 8th day with symptoms of either gastrointestinal upset or a feeling of fatigue. So I noticed that there was a myriad of symptoms that could herald the onset of this 8th day. And so I educated patients not to discount symptoms on the 8th day. So I've had patients who were perfectly fine on the 7th day with absolutely no symptoms at all, completely recovered, and would get up on the 8th day and just find that they had a little bit of body pain. Mm-hmm. And that was enough to tell me something's happening. Wow. I would have patients that would get up on the 8th day and just feel tired through that day. And that's enough to tell me something was happening. So I had to stress the importance of the emergence or worsening of any new symptoms on that particular day. The aim of treating patients in the first 7 days is to plan for what might transpire on that 8th day. So I don't want you to come to me with a bronchitis on the 7th day because you gave the pharmacy and the neighbor and every other person a chance to treat you and nothing worked. So you come to the doctor timeously and give me the opportunity to get you perfectly well by the 6th or 7th day, so that on the 8th day, we will be able to notice any worsening. It's the overlap of the two phases that blur the boundaries and make patients think that they're getting better when there's actually a new process that started up and is hidden by their continuing illness. And so the early aim is to get you well in preparation for what might transpire. I have friends and family around the globe contact me as soon as they develop a sore throat. My advice to them is always, I question them and say, well, if it started today, uh, treat yourself symptomatically. You're better at this than I am. You've treated more of your flus than I am. But next week, on this very day, mark your calendar. And if you notice anything on that day, call me then. Between now and then, it's of no use to me.
Wow.
And every single one of them, we've seen that trend. I've not had, in all that I've seen so far, anyone step outside that, meaning start to deteriorate on the 6th day, or start to deteriorate on the 10th day, or 12th day. It's always
the 8th day. Hold that thought, Dr. Chetty.
Yeah, and that's something that also drew my attention to the pathology. COVID pneumonia is a misnomer. The globe has misdiagnosed an illness. Pneumonia is a progressive illness. It is not something where on one day you're perfectly fine and the next day you got pneumonia and you're in ICU. Infections don't progress in that way. So it was the initial thing that drew my attention to the fact that we're dealing with a different pathology and there's a misdiagnosis here. There's no such thing as a COVID pneumonia. This is a hypersensitivity pneumonitis that is triggered in your lung on the 8th day by an exposure to an allergen that you're allergic to. And hypersensitivity pneumonitis, dependent on the severity of your allergy, can progress within a few hours to ventilation and death. And so
Hold
the
that thought.
misdiagnosis has led to a whole lot of mistreatment.
1 second. We're going to take a quick break. When we come back, Dr. Chetty, you hit on so many things there. I have so many questions for you because you even talked about the comorbidities and the variants, and I want to get to those as well. We're going to take a quick break. When we come back, more with Dr. Shankara Chetty from South Africa. Really exciting and great conversation we're having with Dr. Chetty. We will be back right after. And we're back. You're listening to the Hit Back with Nahaja Black, Guardian Radio 96.9 FM. I'm kind of stuttering right now because we're having such a great discussion with Dr. Shankara Chetty in South Africa. Dr. Chetty, again, thank you so much. The time difference, I appreciate you today. I know that you're doing another great talk and session with the Caribbean event in a few hours. So I really am grateful that you took the time to share your findings with us. One of the things, Dr. Chetty, that's going on in country, we are a country filled with comorbidities, right? We're hypertensive, we're diabetic, we are overweight. You look at us on a map, we're not just beautiful, but we're apparently very sickly, right? And that the fear is that we are a breeding ground, right, for COVID-19, that we are a group of people that are very susceptible to this virus, and that has also increased our challenges, right? Increased our concerns. And so there is this push for all of us to get vaccinated, and we'll talk about that also in the show. But I want to ask you, what have you found with this virus and comorbidities? Is it as scary as it seems? And based on what you talk about with the 8th day and your first patient, I'm thinking that there's some hope here.
I think we need to put the perspective into place, Nahaja. If you equate it to a bee sting, a bee does not care whether you're fat or thin. It does not care whether you're diabetic or hypertensive. The only risk is that you're allergic. It's like crossing a road. Yes, if you're diabetic or you're overweight, it puts you at higher risk of being run over, but you can't go blaming the car. You're just at higher risk. And the risk, the comorbidities, the weight, all those kind of things, put you at higher risk once you've had the reaction. So yes, survival is always determined by those risk factors, but the way they contribute to the illness varies. Risk factors are a concern if the risk factors put you at a greater propensity of death. But a bee, like I said, doesn't care about those risk factors. It only cares about whether you're allergic or not. If you're not allergic, the risk factors mean absolutely nothing. If you are allergic, then the risk factors will play a part in your recovery. So the risk factors do not play an integral part in the risk to the virus. They play an integral part in the recovery from this virus. But the most important factor is whether you're allergic or not. And that's the reason we've seen old people survive this with no real effects. And we've seen young, healthy people die from it. Just to put that perspective to
Please.
you and to fill you in as to the whole picture.
Because I was about to
Uh,
ask that too.
I knew that we're dealing with an allergen, and it was vitally important for me to figure out what this allergen actually was. Now, from understanding the replication cycles of viruses, viruses take over the machinery of the cell and use it to produce proteins and RNA fragments and assemble itself into new virus particles, which we cough out, spread, and that's how it transmits itself to the community. And this has been known. This is how viruses work. And they have a finite life cycle. So chickenpox doesn't last longer than chickenpox does. And so there's always a finite cycle. And from looking at the recoveries on the fifth or sixth day, I knew clearly that this virus, by the fifth or sixth day, had done its trick and it was leaving. Now, when a virus eventually curtails its life cycle, there's a lot of viral debris that gets left behind, fragments of virus. And it was my opinion that it's one of these fragments of this virus that was actually triggering this process. So the viral fragments were the allergen, were the sting of the bee. Now, from very early on, I had my eye on spike protein. Spike protein is the protein on the coronavirus that has allowed it, the change that has allowed a bat coronavirus to infect human beings. It is what gives the virus its propensity for its host. So, seeing that we were dealing with a bat coronavirus that was now infecting human beings, it was most likely to be a change in the spike protein that was allowing that to happen. And of course, we all know when we're exposed to new environments, there's likely to be something in that new environment that we'd be allergic to. So, what was new on this virus was the spike protein. The rest of this coronavirus is something that was common to other coronaviruses that we as human beings have been exposed to in the past. So the spike protein became the center of my focus. I knew from the start that that's where I needed to look if I was looking for an allergen that was new to humanity. And so it was my consideration that I'm dealing with free viral debris on the 8th day that was triggering this process. And part of this viral debris that was likely allergenic was the spike protein. When we got into the second wave of the pandemic, we were afflicted by the notorious South African variant. And so I looked at the genetics of that particular mutation that made the South African variant unique. And that mutation caused a change in the amino acid sequence of the spike protein. So the only thing that changed from the wild type that we were all exposed to globally to the South African variant was the spike protein. Nothing else on the virus had changed. So I looked at clinically what I was seeing in that second wave. What I noticed in the second wave, now the spike protein is actually the glue that sticks the virus to you. And so what I noticed in that second wave was that we were dealing with a far more contagious virus. It was spreading rampantly through families. And that would be spike protein, attributable to a change in the spike protein. I was seeing more gastrointestinal symptoms. People were presenting with runny tummies and upset tummies and nausea. And that would again tie into spike protein, an affinity for ACE receptors in the gut, more than ACE receptors in the lung. And on the 8th day, I was now seeing a far more severe reaction on the 8th day. And so that drew my attention to spike protein being the culprit. It was the allergen, and it was the thing that was causing all the mortality and morbidity that we were seeing. Now, in all the patients that I've seen, Nahaja, I've used this perspective I'm not one to punt protocols. I'm not one to punt medications. Every patient in front of me is different. And understanding the perspective of this illness is vitally important if I wish to save lives. So I knew from very early on that I'm dealing with a hypersensitivity trigger on that 8th day. And the allergen that causes that trigger is spike protein. And if I do not timeously curtail that reaction that ensues, it's going to progress into hyperinflammation. And that hyperinflammation is going to progress into hypercoagulability. And I needed to be quick and aggressive in stopping this process. And I've been through now over 7,000 odd patients in my practice, some of them critically ill. I'm sure you're aware that patients don't want to go to hospital. Very few come back from that intervention. We're still using ventilation, even though it does not work. I think that the pathology has been misunderstood. We're still treating COVID pneumonia when this isn't a COVID pneumonia. And so in all the patients that I've treated, I've managed to timeously reverse the hypoxia that they present with.
Wow.
And very timeously have them improve. So in all that I've seen so far, I've had no hospitalizations, even though I've had critically ill patients present way after the 8th day.
Critically ill being what number? What is considered critically ill? What level?
Well, let me just give you one case. This is a few weeks ago. I had a lady come to me, brought in by her son from a town 160 odd kilometers away. She was on her 13th day odd. She had become very breathless over a few days. He had called out the paramedics to have a look at her. They insisted that she needs to be put into ICU immediately. Her saturation at that point was 40%. She was barely conscious. She was struggling to breathe, not corpus mentis. He refused. He hired the ambulance for the day and insisted that they bring her to Port Edward to my practice. So here I was faced with a patient that had a drip, that had some oxygen on her stretcher, being brought to me with an ambulance. Her saturations on oxygen, 5 liters, was 54%. The paramedics were terrified. They knew that she was going to die from the history that they've seen. I had a look at her. I started her on this intervention. I gave her an injection of antihistamine. I gave her a nebulization with adrenaline, which is used to treat these kind of reactions. So I treated it from my perspective. And the aggression of intervention is dependent on the severity of the patient in front of me. So I put her on the relevant treatment and I sent her home, again with the ambulance, but I instructed her son. I did a blood test for her, the markers that I required, and I explained to them what needed to get done. And this was a Monday morning, and I asked him to bring her back on Thursday for a review. My staff phoned the next day, and she had already shown signs of good improvement. When she had come back on the Thursday, she had her GP from her local town in tow. He was fascinated by her recovery. On the Thursday, when I had examined her, her saturation had improved to 88% on room air. She was still on oxygen, but on nasal prongs. She was able to speak to me clearly. We had a laugh and a joke. Her GP was fascinated. I repeated all her bloods to see that I had turned this reaction around. The common blood tests that I do are C-reactive proteins that tell me the level of inflammation, interleukin-6 that tells me the level of immune response, and a D-dimer that tells me the risk of coagulation. Now, all those were sky high. On the Thursday, when she came back, they had turned around, and I was happy with her progress. I had explained to her GP how I treat this illness. I had advised him that she doesn't need to come back to me and he could do the tests. It was 160 kilometers in an ambulance to get to me. And so he contacted me the following Monday at lunchtime to say that he had repeated her tests. All her markers had settled to normal. She was saturating at 98% on room air and she felt perfectly fine.
Wow.
So a week from 40% ready for ICU, she was now back to normal. I'm unfortunately having to do ICU treatment on an outpatient basis simply because of the fear of patients to be hospitalized. The protocols in hospitalized seem to be not in step with what should be done, and they seem to be enforced by regulators and legislators rather than doctors. And so patients, I had 4 patients out of an overabundance of caution from their fellow family members who decided to hospitalize them, hoping that they would get better care. And those were the 4 patients that demised. Once hospitalized, my treatment was immediately stopped, and doctors refused to communicate with me because they had protocols to follow, and those patients deteriorated and demised. So yes, if the perspective could be well understood by the medical fraternity, at least I would have the tertiary services be able to assist me in those patients that get complicated and may require tertiary intervention. However, there's this fear that hospitals don't seem to be the place to recover. And so I've been left to do this all on my lonesome. However, I have been blessed that I haven't had deaths or hospitalizations in this time. The speed to recovery is vitally important in assessing any illness. I have a doctor here in South Africa who, by no fault of his own, was asked to disprove my work. He had treated patients in the first and second wave using the World Health Organization protocols, remdesivir and the oxygen and the rest. And in the third wave, he was called upon to look at my intervention and how it worked. And I think after the first 4 patients, he tried to make contact with me. And I, by then, was already very annoyed with the silence I was receiving in the country. So I ignored him. I was just afraid of being entrapped in any legislation. And he eventually got to me on my cell phone and thanked me for the work I'm doing. And so I took the opportunity. He knew that it was correct. It was plain to see that I was right. So I took the opportunity to educate him. It's been 3 months now that he's been using my protocols for treatment. And so recently I contacted him to say, look, I've not seen what you've seen. I've not had patients die. So I have no idea of what's transpiring in the world around me. I only have idea of what's transpiring in my world. So it would be nice eventually now to understand what you have seen and how I have made a change in that. So I asked him, I said, look, in the first and second wave, using the protocols of the World Health Organization, what did you see? And compared it to mine. And he said, look, in the first and second wave, remember, he's an ICU specialist who's doing outpatient treatment in tented facilities and home. So he brings an ICU to your home. So he sets up all the machines and the rest to have you at home. He said, look, in the first and second wave, for every 10 patients he saw, he had at least 1 or 2 deaths. And he said, I met you and you promised me to curb the mortality in my practice. And now in the third wave, I've been through over 1,000 patients and I haven't had a single patient die.
Wow.
Now, I believe in God and I think he has his hand in a lot of things. But speed to recovery is what I'm interested in. So I said, look, we're dealing with a different variant. So we need to negate the difference in variants. So let's consider 2 patients that were equally critically ill. And the treatment in the first and second wave compared to the treatment in the third wave using my intervention, and just from the perspective of speed to recovery. So 2 similarly ill patients with different interventions. And he said, look, in the first and second wave, we took a patient with a 70% saturation on presentation to see how quickly hypoxia would resolve. And he said, look, in the first and second wave, with all the interventions he tried, he would only get about a 5% benefit, and it would take a minimum of 3 days to see that 5% improvement. A lot of patients went in the opposite direction and would deteriorate and would require further intervention, hospitalization, ventilation, and the rest. So his marker was 3 to 5 days for a 5% improvement from 70 to 75%. And when he started using my treatment, he noted that he would get the similar patient with a 70% saturation would improve to 85% within a matter of 4 hours, and then to 90% within a matter of another few hours. So I think he understood my lack of need for oxygen. If you could reverse the hypoxia timelessly, there was no reason to stick a patient on oxygen for days.
That's right.
And he has, strangely, he sent me a message the other day. I think I forwarded it to
Yes.
you. Uh, he in the first wave chased oxygen and ran out,
Mm-hmm.
and decided that's not going to happen again because he had to watch all this death around him. And in the second wave, he chased remdesivir and ran out. And so he planned for the third wave and bought 100,000 rands worth of oxygen and 100,000 rands worth of remdesivir. And he sent me a message the other day to say that you've cost me a lot of money. Ever since I've used your protocol, the oxygen's lying in the corner and so is the
That's
remdesivir.
right.
And I'm looking for someone to buy this and take it off my hands. I don't see the need for it anymore. I think that says a lot. We're chasing the wrong interventions here.
Let me ask you something, Dr. Chetty. Um, India, you looked at India, the world looked at India, and that's when we became aware of the Delta variant. I saw something on MyGov India on Twitter, and there was a physician who is using your protocol, and it says inspired by South African Dr. Shankara Chetty, who treated more than 3,000 poor COVID-19 patients successfully using the eighth day treatment strategy. Dr. Kumar intends to reduce the need for hospitalization. How do you feel about when you hear that and your impact in other countries? Um, what have you heard about your strategy in India itself, and how it's so effective against the Delta variant? It's as if the variants don't even matter.
Yeah, the different variants really don't matter. The the difference in variants speak to a difference in the nature of the spike protein. So the different variants will have different propensities for different systems, either the gut or the upper respiratory system or the respiratory system, and a different severity of allergic reaction. But this allergic reaction always occurs on that eighth day. So the intervention, the eighth day, remains pretty much the same. Nothing has really changed. So the variants and our preoccupation with the variants, I think, is driven by vaccinations rather than any long-term benefit to us from an intervention or therapeutic strategy. What happens on the eighth day happens on the eighth day. Whether you eat a peanut or a walnut, if you're allergic to nuts, you're going to have the same benefit, the same detriment, and the treatment remains the same. So I think India uh, has been pretty much at the forefront of understanding this illness. Uh, my staff initially asked me to write an article about my findings. I knew very early on that I was going against the establishment, but it was something I've been doing all my life, and I took pride in doing that. So I wrote this article, and my intention was not to get involved in the governance around COVID and the controversy. My aim was to educate doctors. My aim was to educate patients. And I felt if I educated doctors and patients, then I didn't need anyone's permission to save lives. And so I wasn't going to get embroiled in all the issues that surrounded this illness. So I wrote this article and I sent it out to every friend, every person I knew that could make a difference, every hospital, the Minister of Health in my country. And I also forwarded it to the principal of my college in India that I had studied. And as much as that, I've received silence for almost a year here in South Africa. However, in India, my principal wrote back to me within 2 hours. I haven't spoken to the man in 20 years. He wrote back to me in 2 hours to congratulate me on my meticulous work, saying that he'd love to take this further. I am part of a chat group of the final year students that were my classmates. I haven't contributed to that group in 20 years, yet it's still on my phone, and I see the conversations and what's been transpiring in their country. And one of the friends of mine had passed away. And someone put a post out to say, is there anything new that we can look at? And this is a group of almost 100 doctors of varying specialities that are well published that were investigating this illness. And so I put my work onto that group. And it was amazing. Within 3 weeks, we had discussed everything that my article had predicted, the perspective. And so there was this group of 100 doctors who understood how to treat COVID in India. And they started spreading the word from early on last year as to what we're dealing with. And that slowly took root, and India started to see the benefits of what I was doing. They also understood what was to come. If you understand the perspective, just to show the importance of perspective, in the first wave, we noticed that people over 55 were dying. Those below 55 seemed to be spared. Now, when you get stung with a bee, your first bee sting in your life, if you are allergic, you will not react to. That first bee sting will sensitize you. You will develop inappropriate antibodies. But you will not react to that first bee sting because you do not have those antibodies yet. When you have the second bee sting, you now have been primed with the appropriate antibodies and you will react. So, looking at that, in the first wave, when people over 55 started dying, it was my opinion that this age group of people above 55 had been exposed to a similar kind of coronavirus at some point in their life and had developed the necessary antibodies to have an inappropriate reaction, whereas those below 55 were naive and it was their first bee sting. So it affected people over 55. But that understanding brought a bad omen. What it meant was that in the second wave, people below 55 would receive their second bee sting and would react. And I postulated that we would see far younger people dying in the second wave around the world because of being sensitized during the first. Quite clearly, that has come true. So I think the understanding of the perspective is vitally important in turning this ship around. We are too preoccupied with counting bees and chasing bees and killing bees, but we're not treating the sting. We're not understanding the propensity for this poison. It should have brought up a red flag. If spike protein is the pathogen that is killing people, understand that coronavirus is not the primary pathogen of COVID illness. It causes a flu. It might cause pathology, but it's not the primary pathology that's going to kill you. Coronavirus is just a vector. The primary pathogen of COVID illness that causes all the mortality and morbidity is spike protein and the body's reaction to that spike protein.
And we're back. You're listening to the Hit Back with Nahaja Black, Guardian Radio 96.9 FM. Being joined live from South Africa, Dr. Shankara Chetty. Dr. Chetty has had now over 7,000 patients, 0 deaths, 0 hospitalizations, and no need for oxygen at his clinic, at his practice in Port Edward, South Africa. A demographic that is similar to ours, that has rural areas, that has impoverished communities and an affluence, but he is doing it there in South Africa. Dr. Chetty, I want to ask you now, let's talk a bit about it. When you think of the vaccine or this process of vaccination, what are your thoughts on it? Because we're seeing places that are vaccinated, that should be fully vaccinated. Israel, Singapore. We're hearing about the cases in Gibraltar. We're seeing it even in Boston, Massachusetts, that had a high vaccination rate. Why aren't the vaccines working? And I already know the answer based on, if anyone's listening to the show, we know why. But your thoughts on it, your thoughts on the vaccine overall.
I think the perspective is vitally important. I'm in a unique position in that I haven't had deaths and I haven't had mortality. I haven't had any morbidity from this. In all the patients that I've treated, I haven't had any experience long COVID. I haven't had complications from COVID. So I think early complete treatment negates everything. Now, when it comes to vaccination, I'm not an anti-vaxxer by any stretch. I've taken all my vaccines, so has my son. And I understand what vaccines are meant to do. I understand where they fit in any health strategy. And the vaccine is meant to prevent us getting infection and prevent us transmitting that infection. And so when we deal with any severe viral infection that is highly contagious, vaccines do have their place. Unfortunately, not for the person that's already infected in front of me. So early treatment is the most important early intervention for this and to bring understanding to what we're dealing with. So very early on, I thought vaccines being punted were really nonsensical in view of the suppression of early treatment and all the censorship around early treatment. Now, the vaccine itself, spike protein is the culprit in COVID illness. And when I realized that the vaccines were meant to have your body make spike protein and then trigger an immune response to that spike protein, and that immune response was meant to be beneficial in killing a bee that didn't really curtail the illness itself, I found no sense in it. I was pretty concerned that we were going to expose the planet to this spike protein that I consider to be the pathogen of COVID illness. And so the vaccines have never been logical to me. Early treatment would save lives. In the 7,000 patients that I've seen already, I haven't had a single patient being reinfected. Of course, I guess if I use a faulty PCR test to test every patient, I'll probably find a few reinfections. But nature has a way of giving us a booster whenever we need one. But that booster isn't going to kill us. And so I think the vaccines need to be put into the right perspective.
Before I let you go, for physicians who want to know you more about your protocol, and for someone who's just tuning in, let's say that they just got into their car, they're just tuning in, they're just settling into this conversation, and you had 2 minutes as a physician to give them your findings, your thoughts, and the protocol that you do. In your best 2-minute spiel, it's a TED Talk, that's only 2 minutes. How would you share this information with any physician that's listening to us right now on what you've discovered and the protocols that you use that has allowed you to save 7,000 lives?
I would say that they need to be cognizant that as much as we're aware of the inflammation and the coagulation, and we're treating that around the world, this is a hypersensitivity trigger, and they need to be very aware of that. And simply to add an antihistamine and montelukast to any treatment protocol that they institute, it is the two medications that will make the hugest difference to the outcome. As simple as that. And of course, to be very cognizant of the 8th day. If you have the fortune of seeing a patient prior to that day, then take the time to educate that patient about that day and take the time to make sure you give yourself the chance to intervene timeously and aggressively. But make sure you understand that it's an allergy triggering the process. And if you do not address the allergy, you will never reverse the reaction timeously. So it's as simple as adding an antihistamine and montelukast to every protocol that's out there right now.
Dr. Shankara Chetty joining us on the show. Dr. Chetty, I know you did your first article March or May 2020. I think it was in Modern Medicine. I think it was that the date. Yep, Modern Medicine in South Africa. I've found it online as well. And of course, they can find you on LinkedIn. They can find you on YouTube. Anyone you want to follow Dr. Chetty's work, Shankara Chetty, Shankara Chetty, Chetty. Dr. Chetty, thank you so much for the time.
Just to give your clients, your listeners some information, I never was expected to be thrown into the deep end with this. So I'm in the process of setting up a website so that I can bring all this information together. Everyone asks me, where can I find this? And so I need a home on the internet. It's going to be drshankarachetty.com. We're busy setting it up and getting the right feel to it so that we can bring all my work together. But if you Google my name, Dr. Shankara Chetty Podebud, Google somehow has taken the opportunity to post all the work I've done on my business site. So if you scroll down from that site, you'll see all the stuff posted there. I'm pretty surprised that they haven't censored me as yet. But I guess the truth is the truth.
Yeah. Dr. Chetty, thank you so much again. And please continue the work. Hopefully, very soon. I know after this show airs, which will air on, well, today it's on now, right? So after it airs, though we pre-recorded it, I hope that we can, for about 15 minutes, I know it's live and it'll be about 10 p.m. your time, that folks who have some questions can call in and we can do it live on air as well. Dr. Chetty, thank you so much for the time again. You are a breath of fresh air and a lifesaver for many. And we look forward to our doctors taking on your protocols and us stopping this death in country. Thank you so much, Dr. Chetty. Have a great day.
Thank you. Thank you for giving
All
me
right.
the platform. Thank you.
Well, that's the Hit Back with Nahaja Black, y'all. I don't know how you feel about it, but I know you were just as moved, I believe, and encouraged and hopeful that there is an answer, that there has been an answer, and we are still doing the same things and expecting different results. That is the height of insanity. In the midst of it all, we are losing people, families, sons, daughters, husbands, wives, children at the same clip and rate, and an alarming clip and rate. And we're not changing. All we're hearing is get vaccinated, get vaccinated. But I know now that people who are vaccinated will succumb to COVID-19, can die from COVID-19. So then that can't be the answer. That means that there must be a better way. In South Africa, Dr. Chetty has shown a better way. In India, doctors are using Dr. Chetty's protocols to save lives. Even now, so around the world. And what are we doing? We cannot ignore that there is hope out there. And I hope all of my doctor friends, all of the nurses, tell your mommy, tell your brother, tell your sister, tell your uncle that this show is online. It is on the air, YouTube, Facebook, share it, like it, let everyone know we need a change in how we're dealing with COVID-19. You're listening to the Hit Back with Nahaja Black, Guardian Radio, 96.9 FM. We will see you when we see you, which is tomorrow. We're out.